So I thought before we finish, I thought we should look at where we are and where we might all go.
Big question.
To the pub. It's a quick answer. But actually, you know, it's exciting to see what's happening, and there will be future developments, and we have to merge the whole aspect of pathology, microbiome, and so on with what we do as surgeons and how we're going to improve take that to the operating theatre.
So this is a bit of philosophy. This is a Yorkshire philosophy from what I think I've learnt over the years and where I think it's going from the stuff we're doing in the Bowel Cancer Improvement Programme in Yorkshire. So I think that there's huge scope for Pelican and the sorts of things that Pelican has done over 20 to 30 years because we're not as good as we should be, and so we can be more effective and everybody can get better. But the problem is we don't know which bits we're not so good at. So I think that and different people will be not so good at different things. So we really need to get a handle on the data so that individuals can get their own data and see where they're not as good as other people, and so they can put their efforts into that. And it's going to be different to different teams. So I think data is absolutely essential. But we can't get that data very effectively at the moment. So we should put some effort into that. I think that there's an enormous amount of variation in treatment, and that's been shown multiple times by people like Eva Morris doing national statistics. We need to try and drive that variation in treatment down by identifying what we should be doing and then everybody doing it until we find something else that's better. So, and I think that, that there's variation in surgery, there's variation in the radiotherapy, in oncology, certainly in radiology, and we need to try and drive that away. And I think that levels everybody up, and that would be really good. I think we've forgotten the elderly. We forget that half of the people are over the age of 74, and that we should be looking at those individuals. And I think we've got data now that actually we operate on relatively few people over the age of 75 and not as many as the Danes do. And the Danes get quite good survivals in their elderly and frail as long as they survive the operation. But the issue about the operation is you have to have a low mortality. And the one thing about the Danes is they've driven their operative mortalities down, which enables them to operate on the more elderly. Bill?
It's much better to die of having an operation than it is to die a long, slow death from a bowel cancer. I was told nobody's allowed into the kingdom of heaven with a large bowel cancer, but various things, big politics and people interfering with your practice prevent people doing high mortality operations, and that's very unkind to patients.
But they don't necessarily have to be high mortality operations.
No.
If we get the anaesthetists, as good as they possibly can, and the Danish anaesthetists have really shown us the way with Kellett and people like that, and they've dropped their 30-day operative mortalities, and they're below the UK. So I think better operative mortalities and more operating in the elderly.
And getting away from the idea that you can just shove a bowel cancer to one side.
And
on the grounds of age.
And we probably haven't helped very much by putting all the pressures on surgeons on their post-operative mortalities. So they think, this one's a bit grossy, so we won't necessarily operate on them.
I think where politicians have interfered with surgery, it's nearly always done harm.
Well, I think it's a balance of it, isn't it? And I think there are patients we shouldn't. I mean, yesterday we discussed a patient who's 82 who's got a polyp which looks benign at a colonoscopy, and I said, well, is there any need to remove this polyp? He's on anticoagulants, he's got heart failure, he's got everything. And I said, well, why don't we just see what happens for 6 months? Well, so I think there's a balance, isn't it, Phil?
Yeah, no, it's certainly a balance.
That's better managed early cancer.
Yep.
So.
But you see, we also stopped screening at the age of the end of 74. So before your 75th birthday, you can opt in, but most people don't. And actually, we're missing half the patients. So screening will never affect that half. Yeah. And so should we continue screening? Because a lot of people are going to make 85, 90, 100, and if we found their bowel cancer earlier.
I think it's really important because we have also this, Phil, this is coming out in follow-up. We have routinely, if patients had a bowel cancer at any age, we've said please do a 5-yearly colonoscopy until at least 80. But now the British Society of Gastroenterology come out and said there's no need to bother doing any follow-up colonoscopies, which is wrong because those patients are at increased risk. And also, if they develop a bowel cancer, you want to get it early so you can treat it and cure it.
Oh, you want to treat it locally.
You don't,
so,
exactly.
Don't do the big operation.
So you're better off to have treatment at 85 than at 95. You're going to really have it at 95. So I think that's really important.
And the Danes are doing this better. So that then, the better management of early cancers, because I think that, that's a very specialist operation, especially if you're going to be doing local excisions on it. And then there's the whole issue of contact radiotherapy, which can work very well. So I think we need to improve our management, and it needs to be in more specialist hands.
Yes, there's a lot of over-treatment of early cancer.
Exactly. Yep. That's the other thing, Bill. So it's a balance, isn't it? And when we ran the SPECT program, what we tried to get people to think about, what if this is not a cancer? What if it is a cancer? Well, it's not a cancer. To try and predict what the likely outcome with imaging, with molecular biology, perhaps, all these things.
Then I think we need to be thinking about the future, and you're already doing that with watch and wait. So you've got, given chemoradiotherapy, you've got 10 to 20% with complete responses, and you're not hopefully going to be doing major surgery on those people. It's around about the effects of the big biopsy and trying to minimize the number of major resections. So I think there's a whole area to be looked at there. Then the other sorts of slightly more speculative ones, we really need good data, and we haven't got good national data, and not as good as the Danes, so therefore we can't generate as effective data as Soren would get. And I mean, I can't speak of my rage enough really around about the fact that we cannot get good data, pathology data, we can't get good radiology data, so we really can't do our jobs in terms of making our contribution to managing bowel cancer better.
But that actually is one of the few good things might come out of coronavirus, is that we might actually get better at collecting data, do you think?
Well, the problem is that collecting data was great until 2012, when the government abolished those mechanisms, and they also abolished the National Cancer Team. That data was starting to flow and was enabling us to pick up the variation and was very effective. It all stopped dead. It's been a nightmare the last 8 years to generate the data, and somebody somewhere needs to knock some heads together, because as we see from COVID, data is really important. And if they didn't have the COVID data, they would be in a mess, and we're in a mess because we can't improve bowel cancer because we can't get the data. Politicians need to get involved there, because it's an easy thing to do. They just need to mandate and put the money in. And whatever Public Health England turns out to be, it needs to be capable of collecting good data which can be made available to all of us. Because how can politicians blame us for not being very good if we don't know how good we are?
Can I be really political and say, couldn't we retrain the 40,000 people we've got running the internal market, and
put them into something useful?
Having them talk to the doctors about the things they want to know. I mean, 2012 is when the direct consequence, I would suggest, politically, of backing this internal market, which has not achieved anything, and instead of a proper national health service where the doctors are listened to, the priorities are set by people like you, looking at the areas likely to lead to more patients being saved, suffering, death, and so on. And we've gone completely off the rails in the last 10 years.
And then, we need improved screening pathways and better testing, because at the moment we're identifying too many people, which is wasting lots of colonoscopy time. And what we need are more specific tests to identify who's actually got the bowel cancer and who hasn't got it. So we need to improve that, and we need to extend in age range to get the more elderly people, and we also will have to start to make them younger, because the Americans are now starting screening at 45 rather than 50. And they're going to have to test by fit, and we'll have to test by fit. So we need to make fit better, and there are ways in which we can do that. The last three, well, next two are a bit more speculative. So understanding the preoperative health of patients, so their immunology. If you have high neutrophils, low lymphocytes, you have a 30% worse outcome. And nobody screens for that or looks at that, but they're more likely to get a wound infection, they're more likely to get an anastomotic dehiscence, and more likely to get a recurrence. Something's wrong with their immunology, and that's a simple blood test that we all perform, but we then ignore it. And what's the preoperative bowel health? How good is that person's microbiome, and can we modify that and improve it or take more care of it later? And post-operative health in terms of diet and exercise, I think all of those things are really important. Now, we might say they're out of the realm of a pathologist and a surgeon, but who knows about that. So healthy lifestyles to reduce the coming wave of young cancers, absolutely essential. Good diets, generating good microbiomes, exercise should reduce this coming wave, and that's really important to do. And then the science potentially is really important. So the microbiome might help us with causation and prevention. So that's really important. Circulating DNA is fascinating for recurrence and all sorts of things that we can do with that. And then along come the targeted therapies, which hopefully will enable us to save a few more people. And there's some interesting ones coming through. So that was my sort of almost top 10 thoughts. You'll have something different, and so will everybody who ends up listening to this. But if I had a sort of crystal ball, then those would be the sorts of things that I put my money on in 2021.
Fascinating. And the younger cancers in colorectal is a real problem, and they're younger than 45, Bill. I mean, Phil,
they present late because they've been to the GP multiple times. They don't get picked up.
They themselves or their medical teams, none of us expect a 25-year-old or a 30-year-old, but they do crop up. And I think my impression is that it's an increasing problem. So even if you cut off at 45 for screening, you're not going to pick those up.
No, absolutely. And we need to understand what's going on. Now, there is a suggestion this is a cohort effect. And if it's a cohort effect, then it's only going to get worse. And we need to understand what
tell us what a cohort effect is.
All right, sorry. The cohort effect is where there is something going on in that population in an age group, which differs between the different age groups. So the classic cohort effect is Helicobacter, where the elder groups had higher rates of Helicobacter and the youngsters didn't. And so what we've seen over that is a natural decline in gastric cancer because the Helicobacter rates dropped with age. So that was driving gastric cancer in the right direction. Our problem is we've got something going on with bowel cancer that's driving it in the wrong direction. So the suggestion is that whatever's going on in our sort of 45-year-olds is worse than what's going on in our 35-year-olds, which is worse than what's going on in our 25-year-olds, which is worse than what's going on in 15-year-olds. Now, one of the exciting things about the microbiome is that PKS mutation in APC can be found in normal crypts in 7-year-olds. So you can find these mutations occurring in very young children. Now, what we don't know is whether that's anything to do with it, but I would put money on the fact that there is something to do with the microbiomes of these individuals that is stimulating the formation of these cancers. And there are various studies starting around that sort of thing, but we need to find out what's going on in these people. It's much worse in the States at the moment. We're seeing the start of it, but it's going to come. And we don't want these 25-year-olds getting bowel cancer if we can avoid it.
Speaking as a very old chap, can I say I think young people are much, much more important, and we've ignored them and tortured them with COVID by our selfish and politically misdirected care for the elderly at the expense of the young. I think it's unforgivable.
Well, I think it's a balance, isn't it, Bill, of picking winners, and the thing is that clearly young people with, there's a late diagnosis. That's the real thing we see more with young people. But we see a lot of late diagnosis in young people. That actually, and it's hard because the patient doesn't know and doesn't think they could have a cancer. The doctors, the doctors in hospital, none of us think that. We see somebody 25, we don't think about bowel cancer, but we see 25,
I think
30.
we think that young people's bowel cancers, stage for stage, can be cured just as well
exactly.
They can be.
as the elderly. So
they may be even more
a matter
responsive,
of
more
remembering that it occurs.
They seem to have the same genetics.
Yeah.
So when we look at the 2,000 bowel cancers, whole genome sequencing, they tend to have exactly the same mutations.
But so the late diagnosis probably.
Well, it's the late diagnosis. So there is nothing different about them that we can find at the moment. But something is making them happen at a much more rapid speed. And so either they're getting the inducing mutations earlier, or the microbiome or something else is promoting them more rapidly and they're growing more rapidly. But there's nothing in their sort of background genetics, and there's nothing in the cancer that we know about at the moment that is the cause of it. So it's got to be something that has changed within the environment. And the diet has changed. Obesity levels are up. There's a whole bunch of stuff going on in our youngsters, but we don't know what it is, and we need to do some research around about that.
I think it's fascinating, and I think you've covered many of the really interesting aspects of colon and rectal cancer that are currently topical and likely to keep us all working away for the next years.
For as long as we last.
and I think the great thing is that surgery has a role to play in all of these things. We also need to join in the aspect of working out which patients should have which tests and which treatments. So thank you very much, Phil. That was a fascinating overview of where we are and where you are and where we all should be going.
Well, I just have to say thank you for a 30-year relationship with this man here, and a 30-year relationship with you. And it's been a lot of fun, and we've achieved a lot, and it's been a privilege.
For us
Thank you, Phil. For us it has. You can find a whole series of videos and links to our series of discussions around rectal cancer at this address. And if you have any suggestions what we might cover, please let us know. Thank you very much for joining us.